Okay.
Okay, Dr. Amir, you need.
Yes, sir. Yes, sir. I'm here.
Okay, okay, Bismillah.
Bismillah.
How to master reading radiography in your practice? Divide this part into three phases. The first phase, anatomy variant positions. Alhamdulillah, in FRCR, we covered this part during the first part, followed by traumatic conditions, all traumatic conditions, not just the common, and the non-traumatic conditions, neoplastic and non-neoplastic. I will revise in brief, this part. Regarding anatomy in CT and MRI, usually, not usually, the scapula have an oblique orientation. So most of the dislocations of shoulder will happen in anterior direction because this part is supported posteriorly. It's easy for the humeral head to dislocate anteriorly. It's very hard to dislocate posteriorly. It needs a very strong force, like convulsions, electric shock. So if you see a posterior dislocation, we need a specific type of history. Okay, regarding radiography, usually we image the shoulder in anteroposterior position. What do you mean? There is some overlapping will happen between, you will see this overlap between the humeral head and glenoid fossa. This is the glenoid fossa. Let me see the first and the most requested radiograph in the shoulder, anteroposterior view. It's called neutral. We have here some overlap. It's called half moon. Half moon, very important sign. Okay, there is overlap between glenoid fossa and humeral head. It's a half moon. This is the EB view, but not true AB. Okay, I'll tell you what's the true later. It's very easy to diagnose anterior shoulder dislocation because the humeral head, let's describe it. Humeral head is displaced, not dislocated, displaced inferiorly and medially. This is equals to diagnosis of anterior shoulder dislocation. What about posterior shoulder dislocation? It's difficult because the humeral head displaced posteriorly. How can I judge this dislocation? By half moon sign. The half moon sign will be lost in posterior dislocation. So what about this? There is some widening, some gap between the humeral head and glenoid fossa. It denotes posterior dislocation from this view. Okay, doctor, the clinician want another view to confirm. No problem. We have multiple additional views, like Y view. Why we name it Y? Because it mimics letter Y, scapular blade and anterior part or coracoid process, the spine of the scapula, and acromion process. Humeral head superimposed on the glenoid fossa immediately in the center. But if humeral head, oh, empty glenoid fossa, the humeral head displaced anteriorly, become in a subcoracoid location. This is anterior dislocation. It moves towards the chest wall. But in posterior dislocation, it moves toward away from chest wall in a subacromion location. Note again, the glenoid fossa is empty. And also light bulb sign. No, don't rely on light bulb sign on this view. So lateral view or scapular view or Y view is helpful, but take care. Patient has severe pain, and this position is very painful. The patient cannot do this position during dislocation, so unlikely be helpful. Okay, and also any tiny bone fragments will be missed. Additional view, no problem. Axial view. Uh, how to image axial view? Either inferior, I will put the radiograph or the film inferior, and vertical. direction of the beam from superior to inferior or vice versa. Uh, normally we see the anterior structure, which is coracoid process. Posterior structure, acromion process. What about in the middle glenoid fossa? And normally the humeral head superimposed in over glenoid fossa. But Dr. Ismail, the surface here is so small for this large humeral head. Okay, but we have labrum, cartilaginous labrum. It helps in stabilization, which is MRI structure, not radiographic structure. Okay, in anterior dislocation, very easy. Humeral head moves towards coracoid process. In posterior dislocation, it moves towards acromion process. It's very helpful, but again, patient cannot do this form of movement during dislocation. It's painful. So what can I do? Anterior shoulder or posterior shoulder dislocation, يعني difficult to form or to do axial or lateral scapular view. What can I do? Through AB view. Okay, how? It's easy. The AB view, usually the beam will be directed from anterior to posterior. Make some obliquity, angulation of the tube. Okay, this is the AB view. But if we angulate the beam like this, 45 degree, it's called oblique view. Okay, now you see no overlap. The beam runs through the joint space. Okay, no overlap. And the coracoid process may be overlapping the humeral head. Unlike this view, the coracoid process is away, far away from the joint space. So this is oblique view and apical view. Again, 45 degree from the horizontal beam and 45 degree toward the apex. So two angulations is done. So this view is named apical oblique view or Garth view. Unfortunately, this view is not commonly done at Egypt, unfortunately, but it's very helpful. See now, no overlap accepted. This is the normal view, by the way. No overlap accepted in this view. A loss of half moon accepted in this view. You will see abnormal shape of the scapula. This is normal for this view. You will see some overlap between the humeral head and coracoid process. Does it help? Very helpful. The patient didn't move his hand, so it's painless view and easy to discriminate between anterior shoulder dislocation and posterior shoulder dislocation. In anterior shoulder dislocation, it moves towards the coracoid process, again towards the chest wall with this sign. Okay, it's a Hill-Sachs abstraction. And in posterior shoulder dislocation, it moves towards the acromion process. So apical, oblique, or Garth view is very helpful to determine the type of dislocation, and it's painless. No need for patient movement. The patient is holding his arm with the other arm, like in any neutral view. Okay, and also it's helpful for to detect glenoid fractures and Hill-Sachs fracture. Non-painful. Okay, so this is a brief, it's a summary, by the way. Okay, it's not detailed. The summary of the positions of the shoulder, EB view, true EB or Garth view or apical oblique. This is the best terminology, by the way, because true EB may be another view. Apical oblique is the most commonly done at UK. I don't know, يعني maybe you don't يعني know this position at Egypt because I worked at many hospitals, including orthopedic hospital. Okay, this position is done in UK routinely. Okay, so if enough RCR, you need to know this position, and we have a pitfall here, my friends. I will tell you in a minute. Take care. During AB view, the hand should be neutral. The arm should be neutral. Look to the fingers. Okay, but sometimes I need external rotation if you are suspecting a greater tuberosity fracture. So EB view with external rotation, with exo rotation. Sometimes with internal rotation if you are suspecting something in the lesser tubercle. Okay, so if suspecting something in the greater tubercle, external rotation, lesser tubercle, internal rotation. Take care. What most patients with anterior or posterior shoulder dislocation cannot move the arm. So they held the arm fixed in internal rotation and held with the other one. So if you see this view, it's called light bulb view. Maybe just internal rotation. It's not posterior dislocation. Okay, how to differentiate between posterior dislocation and internal view, internal rotation by overlap sign. Again, overlap sign, the half moon sign. So two pitfalls in positioning, very important to be known by all of us, especially my friends at Egypt and KS and Saudi Arabia also. When you see, oh, there is half moon sign. Okay, this is the usual EB view. But if you see no gap, just a minute, no gap doesn't mean dislocation. Look to the shape of glenoid. And here, oh, looks like line. Look to the shape of coracoid, and here some overlap. This is apical view, apical oblique, and also the shape of the scapula. Okay, apical oblique view accepted, accepted. No overlap between glenoid fossa and humeral head. With the joint space can be seen clearly. Any chondrocalcinosis can be detected. Foreign body, radiopaque foreign body also can be detected. Okay, so it's very important to differentiate between both views before you diagnose posterior shoulder dislocation. Okay, loss of half moon sign is an important sign in AB view, not in apical oblique view. Okay, loss of half moon sign important in AB view, not apical oblique. This is the first note. The second note, oh, light bulb sign and light bulb sign. Sometimes, this is very clear, of course. Look to the overlap in EB view. In EB view, look for the overlap. If there is overlap, usually this is internal rotation. It's not posterior dislocation. But if there is no overlap at all, okay, with this classic light bulb, you may diagnose posterior shoulder dislocation. Okay, if you are suspecting a greater tubercle, okay, the classic view will be external rotation. EB with external rotation. Now you see greater and lesser and intertubercular groove. It will be very clear. We call this view a walking man or a walking man stick. Okay, if this stick in position, no shoulder dislocation together with the half moon sign. Okay, now to short reporting. Sorry for this basic informations, but this is what يعني all of us should do in our practice. Revise the positions, revise the pitfalls, modification of positions. It's our rule to guide younger colleagues. It's our rule to lead technicians how to perform, what to do. Thank you, boss. Okay, so positions, anatomy, variance. This is the first step. By the way, يعني I started this step at the age of 37. No problem, no problem. يعني after master degree and after every exam يعني I faced and no one guided me like this. So I had a defect in radiography till the age of 37. Very large, very big defect. But after that, Alhamdulillah, now I'm teaching radiography. I'm leading all technicians in my department how to do optimum radiographs. Okay. Okay. Let's start now short reporting and what to do in exam. This is an example, my friends. إذا أنا وإياكم. An example of a musculoskeletal radiograph. I'll take the shoulder as an example. In the exam, you may face a trauma, dislocation, a trauma, fracture, a trauma unrelated fracture like rib fractures in case of imaging the shoulder, non-traumatic conditions, non-neoplastic conditions like osteochondromatosis, neoplastic conditions like benign or malignant, and finally unrelated pathology like lung pathology, pleural pathology, rib pathology, and so on. This is the way how to study radiographs for short reporting. Starting with my friend Dr. Umair. Okay, you will start with
Okay, sir.
me in short reporting. Just
Okay, sir.
describe it as a short case. What to do?
Okay, sir. I'm sir, extra shoulder, frontal projection, left shoulder, in which I can appreciate that there is anteroinferior dislocation of the left humeral head is noted, and no other bony injury can
You
be
said
appreciated.
you said you said antero-inferior
Yes, sir.
antero-inferior dislocation. Take care, take care, because we have a subtype of dislocation. Of
Okay,
dislocation, it's called inferior.
okay, sir. Okay,
We have anterior, we have posterior, and we have extremely rare type. It's called inferior dislocation or luxatio erecta. When you describe, it's better to describe displacement because
displacement,
dislocation is a diagnosis. Displacement is a descriptive term. So
description.
we
Okay,
have infromedial displacement of humeral head. Okay, continue,
okay, sir.
boss.
Infromedial displacement of the humeral head, and then I can the rest of the visualized bones, lungs, tissue, ribs are unremarkable. So I will refer the patient to the orthopedic surgeon for further management of the case.
Okay. Very good and very summarized, yeah, boss. Okay. So, as we said in the chest, we have to describe the main pathology, okay, whether positive and negative, and the rest of radiograph. Then we give diagnosis and we give a management.
Management.
Here, يعني you did all steps good, but we need extra management. Regarding describing the finding, yes, it's infromedial displacement of the humeral head in relation to the glenoid fossa. No air fluid or fat fluid level could be seen. If you see here fat fluid level, it means intra-articular fractures. It
Oh,
means CT scan. Okay, if you see here or in the knee, fat fluid level, hypo,
levels.
hyper, it means interarticular fracture, even if you cannot see it. So one step in the management is mandatory is CT scan. You commented on this joint. Please, we have another joint. So in negatives also, no fractures. Why no fractures? No glenoid fractures. You should mention here, by the way. Okay, intact
Okay, sir.
glenoid fossa, no glenoid fractures. The rest of the radiograph, normal acromioclavicular joint, normal ribs, and visualized part of the lung. Very good. Diagnosis, left, don't
Mm.
forget please, side, left shoulder dislocation. You said here, discussion or discuss the finding. Okay, one. Discuss the finding with the referring physician or urgent referral to orthopedic. Good. But first, let's see here. Review other views if available, because sometimes we may have a lateral view, a scapular view. Write it. This good step in the management. Review other views. Discuss with the clinician. Number three, any additional thing that may be done in case of anterior shoulder dislocation? Any
Uh,
additional step? CT, I don't think no fracture, so no need for CT. MRI, MRI
am I
may
right to
be
look for any ligamentous
yes.
injury?
Yes, but we should write يعني a good sentence. MRI shoulder may be helpful if clinically needed because it's not routinely done. Okay,
Okay.
if clinically needed after resolution of the edema and effusion is not done in the acute phase after 2 or 3 days, MRI is helpful if clinically needed after resolution of the edema and soft tissue swelling. Very good, yeah, boss. Okay, second case, proceed 22 years with painful shoulder.
Okay, sir, I'm provided with a radiograph shoulder frontal projection of a 22-year-old male who presented with painful shoulder. And sir, I can see that so there is a defect noted along the posterior and superior aspect of the humeral head.
First,
With
before description, you know what is this?
sir, this is greater tuberosity.
No
No.
problem. Anyone? What is this? Write in the chat because yes, yes, it is.
Okay,
Yes.
deformity, yes, sir. Hillside deformity, yes.
Yes, yeah, boss. Okay. Okay. So we have to know the appearance of Hill-Sachs and the reverse Hill-Sachs or trough sign, the appearance of inferior glenoid fractures, the common associations with shoulder dislocation. The
Dislocation,
only
yes.
finding here is this slight depression at the superior lateral aspect of the humeral head with underlying sclerosis. Every
Mm,
other thing is normal.
normal.
Okay.
Okay.
Okay. This is regarding the findings. So, diagnosis,
Sir, it's sir, Hill-Sachs deformity, likely due to recurrent shoulder dislocation, and
excellent.
would look other views, and
Yes.
then I would refer the patient to orthopedic surgeon for discussion and MRI if clinically need
MRI now is needed.
to look for Bankart lesion. Bony Bankart
Yes.
lesion is not seen. To look for ligamentous Bankart injury.
Okay, to assess the internal integrity of the shoulder joint. So,
Yes.
again, very good, yeah, boss. Discuss the findings, review other views,
Mhm.
and MRI of the shoulder. And also another review. Review history of recurrent shoulder dislocation or previous
Dislocation.
shoulder dislocation. You need to mention history in your management. Okay, yeah, boss. These two items regarding the trauma. Coming now to 6, 7, and 8. Okay. 70 years old male with non-traumatic shoulder pain.
Okay, sir. I'm provided with X-ray shoulder, right shoulder frontal projection, in which I can see that there are multiple round differential size calcific bodies noted in the synovial cavity, and then I can appreciate that there are degenerative changes noted in the
Good,
shoulder joint as well,
good.
and no acute bony injury or bony fracture or dislocation can be seen,
Good.
and the in the visualized lung fields I have suspicion of an of some
Yes.
opacity, which will I would like to confirm on the complete chest view, or previous history, or previous radiograph if available, or I will advise complete chest radiograph for this.
Very good.
And
And
sir, so
also complete the study by maybe MRI for
uh,
superior
this
assessment.
will be
Very good,
yes,
Yabos. Very good. We have here synovial osteochondrosis, multiple
osteochondromatosis,
ossific
yes.
intra-articular bodies. The secondary effect, narrowing of the joint space, subchondral sclerosis, subchondral cystic changes. It's a secondary effect. Okay. Maybe also some acromioclavicular osteoarthritis. This is the step one. But I'm suspecting something here, which may necessitate, usually in the exam, by the way, يعني one pathology. I يعني I'm not encouraging two pathology in the radiograph, but we will see. يعني this is the first experience we will gain. We need here a full chest radiograph and correlation with maybe occupational history, because this may be a form of fibrosis. Okay, I don't know. So we have osteochondromatosis and something like fibrosis. A full or formal chest radiograph is needed in this case, in addition to maybe CT scan for confirmation. Okay,
Yes.
boss, this is number six. Number seven, easy.
Okay, sir. Okay. X-ray right shoulder frontal projection. I can appreciate that there is a lytic extensile lesion noted in the metadiaphyseal region of the right humeral head, and with a broken fragment noted all through this lesion. And I would now review rest of the radiograph, which doesn't show any other fracture or dislocation. The lung field is also unremarkable. Now, I would like to review any other view if available, and I
Good.
would convey my finding to the referring physician. So it's likely aneurysmal bone cyst or simple bone cyst with the fracture, and I would refer the patient to orthopedic surgeon for
Good.
further management and
MRI also
MRI
maybe
if MRI
helpful.
if
Okay.
clinic. Yes, sir. Yes, sir, if
Yes,
clinically needed.
very good, very good. Okay, as you said, it's benign lesion. It's fairly
Yes.
defined lesion in the proximal metaphysis of the humerus, lucent center, fallen fragment sign with fractures of the cortex, no preosteal reaction, no negative, no aggressive criteria, no
Okay.
aggressive criteria. Okay, it's a simple bone cyst with pathological fracture. Good يا boss. Let's discuss the final case. Okay. Shoulder pain, 55 years old. Shoulder pain after fall.
Okay, sir. I'm provided with the left shoulder projection of a slightly mature patient, in which I can appreciate that there is a fracture noted at the left humeral neck. However, there are lucencies noted underlying this fracture, and it's likely a pathological fracture. I would review rest of the bones, which appears to be unremarkable, and the lung field is also visualized lung field is also unremarkable. So I am highly concerning for pathological fracture of the left humeral head. I would correlate. I would ask for any other review if available. Correlate with the previous history with the his. Sir. Okay, sir. Okay, sir. Okay, okay. I can
He
see an
said,
opacity.
okay,
Yes, sir. Yes, sir. Okay, and now I can appreciate an opacity in the left lung field. So, which I would like to
with the speculated
further
border.
speculate with speculated and ill-defined margins. So for which I would like to further investigate. So I would advise the CT chest, abdomen, and pelvis
Yes,
for the further workup and management of this patient, and also bone scan and refer the patient to pulmonary MDT for further workup and
and
management.
pulmonary cancer. Very good, yes, very good. So it's pathological fracture. Okay, if you are suspecting any pathological fracture, here really I deceived you by fall history of trauma. Okay,
Hmm.
but
Hmm.
please in the exam, please check the lungs, check ribs, check the hilum, lung apex, any pneumothorax. It's
Hmm.
very, very, very important. Here we
Hmm.
have a pulmonary nodule with speculated margin. It's lung cancer. So
Yes.
definitely this is a pathological fracture. We need a frontal or formal chest radiograph followed by CT CAP. اوكي.
Yes. Sir. Yes.
محدش يشخبط. Do not annotate يا شباب. اوكي. Thanks دكتور عمير. All
Thank
eight
you, sir.
candidates are present or no?
Sir, we have one candidate missing. Rather, two candidates are not present. So I have
Good,
few
good.
backups.
So
We will see.
we have six candidates. Okay.
Yes, sir. Right now we have
Good, good.
six.
Okay. خلاص. Let's continue the cases with you يا boss. Okay. Uh, this case number three.
Okay, sir. Should I present it?
Okay, okay.
Okay, sir. So X-ray right shoulder frontal projection of a skeletally mature patient, and in this X-ray, I can appreciate that there is uh, displacement of the
What
humeral
is this
head.
view, yeah, boss? What is this view? Just between me and you, not for the exam.
Sir, this is
EV or apical oblique?
apical oblique,
Yes, abnormal shape of
abnormal
the
shape of the scapula.
abnormal
Yes,
configuration of scapula, and here
yes.
coracoid process is overlapping the expected site of the head. Okay, so
Okay,
very easy to diagnose anterior or posterior dislocation.
sir. Posterior.
Yes, because it's directed
It's
towards
direct towards the scapula.
acromion,
Acromion.
not the chest wall, not the coracoid. Very good. And this sign is named,
Sir, I have no idea.
you need to revise, yeah, boss. Trough sign,
Okay,
okay? Trough sign.
okay, okay.
Lucent line and the sclerotic line. Okay.
Okay.
Start to describe.
Okay, sir. I am provided with apical oblique view of the shoulder, right shoulder, in which I can appreciate that there is posterior dislocation of the shoulder is noted, and forming the trough sign, and glenoid and rest
Okay.
of the visualized bones,
Okay.
ribs and visualized lung is unremarkable. So I would ask for any other view if available,
Good.
and convey my findings to the referring physician and refer the patient urgently to the orthopedic surgeon, and MRI
MRI may be helpful if clinically warranted or
indicated.
clinically needed after sub or resolution of the edema. Very good, yeah, boss. Another one, here is abnormality,
Okay, so this is like a displacement of the acromoclavicular joint,
superior
superior
displacement
displacement of
of the of the clavicle in relation to the acromion, because the
acromion.
diagnosis should be different than description. And also we have,
Cracoclavicular ligament tear, which is resulting in increased cracoclavicular space,
yes, increased coracoclavicular distance suggesting
distance.
of ligamentous tear. Everything else is
The
normal.
same.
It's
Okay.
acromioclavicular, right? Acromioclavicular dislocation. Again, review other films, can discuss with the clinician. MRI if clinically good. Uh, 75%, no need to mention the grading. Just superior displacement is, I think, grade maybe 3 or 4, but no need.
Okay.
75% of the cases will be in adult, 25 in children, like simple bone cyst in child or this type of injury. 15-year-old boy with progressive shoulder pain, volleyball player. What is the abnormality first? Do you see it?
Mm,
No problem, no problem. Okay. Anyone? The history is very suggestive to a certain type of injury. Yes, correct, correct,
widening of the faces, yes.
correct. It has a certain name, by the way. Yes, it's Salter Harry Swan, but it has a certain name. Anyone know? No problem. Little leaguers, yes. Little leaguers shoulder. Little is like little leaguers elbow. We have here widened physis. Widened physis. No epiphyseal or metaphyseal fractures and no other fractures. It's called, or the diagnosis, Salter Harris 1, like slipped capital femoral ellipse. This is left humeral. Okay. So Salter Harris type 1 or little Leaguer's shoulder. Again, review other radiographs. But here, referral to pediatric orthopedic
Orthopedic
team.
surgeon.
Pediatric orthopedic team. Okay. Very good,
Okay.
Yabus. We discussed this one, and with this one, what about this one? Old patient, non-traumatic shoulder pain.
S- Some multiple lytic lucent lesions throughout the visualized bones, and
Good.
also reduced bone density and some healed fracture of the clavicle. Sir, I am concerning for semi differential would be multiple myeloma or METs, and I would I would correlate my findings with the history of the patient and other studies if available, and I
Good.
would sir
So review other studies,
other
discuss with
studies.
the clinician, okay?
Yes, sir.
And management here.
Sir, I would
Myeloma
myeloma
screening, okay?
screening.
Or
Yes.
myeloma workup. Like what?
Work. Sir, in myeloma, we sir work up by sir skeletal survey and bone marrow biopsy.
Okay, maybe here some soft tissue swelling, by the way, and ignore it.
Okay.
Okay, bone marrow biopsy, very good. Blood test like CBC and
CBC and
protein
LDH.
electro for serum protein and urine electrophoresis, and
Mm.
in UK, I think full body MRI. Okay,
Yes. Yes.
yes, very good, yeah, boss. The last case, I think this one. Shoulder pain after trauma.
Okay, sir.
Mm.
X-ray frontal projection of a 60-year-old female. Sir, I can appreciate that there are fracture of the ribs noted. Sir, I
Good.
have count them. I guess this is first, second, third, fourth, fifth, and sixth rib are
Very good.
fracture.
Five, six
And
reps.
also, I can appreciate that there is a area devoid of lung markings with a
Good.
pleural line seen. It's likely sir, representing a pneumothorax, and rest of the
Everything
um,
else is normal except for
normal.
some
Some
osteoarthritis.
calcification. Yes, sir. So
Very good.
I will
Very good.
urgently pick up the phone and refer the patient for chest to the emergency physician for chest tube placement for pneumothorax. This and then, sir, in management, I would sir
Formal
also
chest
formal
radiograph.
chest
Okay.
radiograph to look for the
Yes. Yeah.
fractures of the
This
other
shoulder.
ribs.
Okay.
Yes, sir.
Okay. To assess the amount and the degree of pneumothorax. So
Pneumothorax.
this is left-sided pneumothorax with rib fracture. This is the main diagnosis. During
Yes.
description, okay, I'll describe some osteoarthritis, but no need to mention in the diagnosis. Okay.
Yes.
And the
Okay, sir.
management, as you said, it's urgent because
Urgent.
the need after يعني, after chest radiograph, we review the need for chest tube placement. Okay,
Okay.
thank you, يا boss. So in summary, my friends, okay, I will show you the pneumothorax. Okay, you see here, this is the lung edge. This is the lung edge. This line is the pleural line. Is the lung edge. And this area completely devoid of any lung markings, unlike this one. This is lung markings. This is jet black lucency, jet black translucency. This is definite pneumothorax. And this is a fracture rib. In the exam, you have many tools. You can zoom, you can change the degree of brightness and contrast. Okay. So in summary, my friends, during your revision, please deal with each joint in this way. A traumatic condition, dislocation, what could dislocate it in the elbow, in the wrist, a common dislocation, for example, in the wrist, lunate, perilunate with fracture or without fracture, metacarpals, fourths and fifths, interphalangeal joints, even drudge, distal radio-ulnar joint. What are the common fracture types, okay, and associations, and the non-traumatic conditions like what? Like arthritis, like metabolic or endocrinal, and like benign or malignant. And
Mm.
review the common workup. For example, metastatic workup, myeloma workup, budget workup, and so TB workup, sarcoidosis workup, just prepare yourself, because in the exam, if you keep this in your mind, inshallah, you will answer these cases in no time. In no time. This will be the easy cases. I'm expecting from the 25, yani maybe five very difficult. I'm expecting this. But no problem. We have 20 cases. Every case less than 4 minutes. Then we will have many minutes remaining. يعني enough time إن شاء الله رب العالمين. Okay. Thank you. Thank you يا boss.